All right. Hello, America. Hello, Oakley, Kansas, Washington, D.C., the Air Force community, everyone out there. This is Justin at Seeking Context. I'm here with my friend and Air Force veteran, Jeff Skinner. Jeff is a radiation oncologist in the Washington, D.C. area. He's a classmate of mine from the Air Force Academy. We graduated and were commissioned as second lieutenants in the Air Force exactly 25 years ago today. And so this episode is a Memorial Day episode for veterans. We're going to learn about what it's like to be a physician treating cancer patients, what it's like to do that in the military, outside the military, and learn about the life and times of Jeff Skinner. And so, Jeff, welcome to the podcast.
Thank you, Justin. Thank you. Glad to be here.
I made another name tag, William Kempton Jefferson Skinner. Is the third? Are you the third?
It is not, but that certainly sounds that there's some components of that are correct.
Okay. Well,
it does sound very nice.
Well, anyway, we'll just leave you as Jeff Skinner. But welcome to the show. And I wanted to just start out by, having you tell me about your job and your life today. Yeah. You're a radiation oncologist. What did those words mean? And when you leave Brenda in the morning after breakfast and go off to work, and you come home and pick up the kids from school, what happened in between those two periods of time?
So first, in general, radiation oncologist, and people call me a radiologist, and people are still confused. And I didn't know that radiation oncologist really existed when I was even in medical school. So I cut people, a lot of slack with that. But ultimately, what I do is there's three ways to treat cancer. You can cut it out, you can poison it, or you can bombard it with radioactive photons to kill the cancer. And so I bombard it with radioactive particles that damages the DNA and kills the cancer. So that's what I do. In terms of my daily day, I'll kind of give you two views of that. One is I don't know if anyone's seen the interviews for The Office, for the casting for The Office, if anyone's seen that. But whoever did the casting nailed it in terms of getting the right people. And you could see how not having the right people in that show, and we enjoyed watching that show, could make, really made a difference. So I'm going to give you my Jim Halpert first, and then I'll kind of tell you the other part. So the Jim Halpert version is, I get up, I drive to work, I see patients that are referred to me for cancer. I look at their pathology report, their labs, their radiology, make an assessment as to whether radiation would be helpful or not. And if it's helpful, then they come back and we do a planning session. If we're going to do external beam radiation, which is radiation from the outside, they come in, we get a CT scan in the treatment planning position, and I take those CT images and I define the target, the area that I want to hit, and then I define the organs at risk, the areas that I want to try to avoid side effects, and I draw those out on a computer. And then there's a dosimetrist that takes that along with my directive, which is how many treatments I want to do and how much dose that I want to give, and they have a list of the constraints, meaning what I don't want the organs at risk to not receive or to not to exceed. And then they use a fancy computer that gets a plan. And then a couple of days later, I look at the plan and decide whether I like it or not. And if I like it, we go with the plan. Patient comes back, they start treatment. And I see them once a week, and we kind of march through treatment. And I manage any side effects that they have during treatment. They finish treatment. I talk to them in a month and see how they're doing and manage those side effects. And then they start their survivorship, and hopefully they're cancer-free and side effects are minimized, and follow them out. During that time, I will see patients in follow-up during varying stages of 1 month, 3 months. I'll start getting some reports as to how well they're doing, manage side effects. I go to the operating room twice a month where I put needles into people's prostates and drop little radioactive seeds into it. And that's a different way to give radiation for prostate cancer. And then there's one day a month that I inject radiation through people's veins, and it's radium. It's similar to calcium, and it goes to areas that have disease and radiates disease in that way.
So yeah, so you decided not to go to pilot training, but you kind of became a different kind of bomber pilot. It sounds like
a different kind of bomber pilot. So that's a Jim Halper. Now, what do I really want to be doing here is and kind of why so why oncology? And this is going to touch on a number of different things. So what I want to do is people come in to see me, and when they come in to see me, I'll come in and say, hey, Jeff Skinner, I'm a radiation oncologist, and I still sometimes they may not even know what that means, and maybe I'm still learning how to communicate better with people.
Yeah, both of those words. I don't know what radiation is. I don't know what oncology are. I think even me, I'm still not really clear.
And it still is, and I'm so used to doing it. It's still hard for me to slow down. I'm still looking. I'm developing a new kind of educational program to try to help people, figure it out. But hey, Jeff Skinner, I'm a radiation oncologist. I use radiation to treat cancer. Happy that you're here and try to immediately try to make them feel more at ease and it's kind of you ask that typical how you doing and depending on what they say, I will acknowledge that this is probably the last place that they want to be, and I'm probably the last person they want to be talking to about something. But it gives me my first kind of start as to where they're at, and then I ask them what they want to be called. If they have a significant other, I want to know that name, and then where do they live, and then I ask what they do, and sometimes I'm not sure if that's necessarily the best question to ask, but I got to kind of cut to the chase now. But I try to find something about them that is different about them. Been challenging the last year with a mask that some of these people have no idea what they look like. Although I'll be wearing a mask and they say I look just like my pictures, and which maybe my eyes do. But so the immediate is getting to know them. Then I try to go over their medical history to get some idea of what they're thinking, how they think about their disease, how they think about themselves, how much information they can process. And how they, some people have no idea what's going on with themselves. They have no idea their medications. They have and so just try to get an idea of what they do know and what they don't know, while I'm getting useful kind of information. It's still hard to kind of tease out. I can get some parts of it, but what they're worried about, what their objectives are, and that's something that is. For me, I kind of focus on prostate cancer alone now. So that's something that I'm wanting to do more and more of, helping to kind of acknowledge, what is important for them. But I can get a good amount of information about at least how they operate by going through their history. And I need to do that anyway, so I can kind of move forward. And then once we get to that part, I kind of an idea of their medical history, we talk about their prostate cancer. And for me, it's prostate cancer it's complicated, but it's pretty simple for me to it doesn't take me very long to figure out whether someone's got a big problem or not, at least in the short term. And, there's, prostate cancer, there's low risk cancer that really isn't a cancer at all, and we just call it a cancer and we treat it for an insurance policy. There's intermediate risk that could go either kind of way. And then there's kind of lethal prostate cancer that could be, deadly in the next 5 years. And so it's not hard for me to kind of get that information. And so I'll tell people, right away, if they don't have a big problem, you don't have a big problem, and we're really here for an insurance policy. And hopefully if I've done a decent enough job of, being a trustworthy fellow and building some type of relationship in that initial 10, 15 minutes while we're going through these other things, that takes a little bit of the pressure off. And if it's not, if they do have a problem we need to take care of, they understand I'm a straight shooter and I'm telling them what we got to do. But those are actually the more simple cases because, I give them the hammer in terms of being as aggressive as I can with the treatment. So it's not as complicated for me to kind of sort through what my treatment options are.
This sounds very time consuming to learn all of these things about one person when you probably have lots of patients.
Yeah, so what I try to do is I try to prepare. So I'm prepared for next week where I've got enough information. I've got the information on the patients for the upcoming week, and I kind of know where I'm going. So I kind of go in with an idea of knowing who they are, at least by their disease, and then it's just linking up the disease to the person and trying to uncover anything that may change. There's things that if they have bowel disease or they have quality of life issues that can make my side effects a little bit worse or not, and kind of tinker around those edges. But none of this is an emergency that needs to be done right away, and so I can use a little bit of time. It's hard to keep track of lots of people who I don't see their face. That's been a little bit of a challenge when you're talking about numerically seeing 10 people who are essentially have the same disease. That's what I do now, which is different than I did in the past. But each person's an individual, and some of them are quite different in how they approach their diagnosis.
So, like next week, how many new people will you be seeing? That, like, you're reviewing like medical records tomorrow, and you've got 5 new people. How does that work?
Yeah, so probably 6 to 10 a week are kind of new people. So that and that's it takes probably 4 or 5 hours to kind of do it, and that's do that kind of throughout throughout the day. And again, some of it's just getting the information available, and this is where if the technology and the way the medical system work was there's systems issues that can make it easier, but sometimes it can be hard to get this information. I think the big difference for me going from the military to the civilian was I didn't realize fax machines were used as much as I didn't think we used them anymore. But they're used often.
Why? For what?
Because the problem with transmitting things electronically is there's so much rules with encryption and the regulatory component of being able to transfer things electronically. You don't have that with a fax because you don't have to worry about maintaining the kind of the chain of custody for sending it electronically.
That's interesting. So who are you receiving faxes from? Like the person's other doctor from some other facility? With a scan?
Yeah. So and this is again from the military. I mean, there's a lot of there's positives and negatives in anything, but in the military system, it's all under one system. You may like it or don't like it, but it's all there. But here you've got pathology that's done somewhere else. You may have a second read that's done somewhere else, notes from another, and none of this is connected. There's some ways you can connect it, but then you got to, does the interface work? How do you sort out, did it get sent? Did it not get sent? Where was the human involved? And so we've created, you see these initiatives, and they sound like they're very helpful, but they're very costly to implement. And like many things, you'll probably understand the lowest bidder, and we'll work around it, and then it doesn't quite accomplish maybe what it is intending to do because it's not as easy as you would think it would be.
Right. So electronic medical records, EMRs, are nowhere close to the dream of improving efficiency and making everyone's life easier.
Not for, and I don't know if there'll ever be. And some of it, until there's maybe some ways you could have patients own their data, but the problem is patients don't necessarily know what they need, and they don't even know if I'm a radiation, what does a radiation oncologist do? And so there's so many challenges with having a very complex system that is secure, safe, does what it needs to do, makes money for the people that need to make money for them to pay for it. It's complicated.
Right. So go ahead.
No, I was going to say, but again, having some simplicity in the system in place, it's prostate cancer is not that complicated. for me in the initial setting.
So it's not complicated for you now, but I'm sure that it took a while to get there. Like, how long does it take to become competent or proficient at being a radiation oncologist? It's a long path. Were you competent when you got out of residency?
Yeah, so I graduated from the Air Force Academy and had a pilot slot and had a medical school
I remember.
at the same time, which was really was a challenging challenging time, and still I'm not 100% sure what could have been different and had different routes been taking. And that's when people say like they never have regrets. I always wonder, well, did you undersell on what you could have done? That was the case. And I guess regret is, what's the definition of regret is
Right.
a part. But
you're kind of saying, am I 100% confident that the decisions I made were perfect?
Right.
And you can't be sure.
Well, I think a lot of people. I mean, a lot of people who went to the academy. It's kind of, I don't know, was that sliding doors or that that was you start looking at all of the kind of big decisions that you made, and the consequences. I found I was cleaning out some stuff with my parents, and I found my pros and cons for going to UVA or Virginia Tech versus the Air Force Academy, and
a list.
A list, yeah. And so and the ones for going to to UVA were much longer than the Air Force Academy, and I think the final one was if I don't like it, I get 2 years of free and I can come home. Was like the final one. And I don't know how much how much you really can think through some of these decisions. I didn't know. I didn't have enough information. And if I would have had enough information, I don't know if I would have done it, because it's a lot, and who knows what would have happened. And I think some of it is having that experience of doing something that was, I don't know, hard and special and different, and kind of pulling it off. It makes you think maybe you can do it again, and in other parts of your life. And so I've made enough. I still feel like I'm making decisions that there's just no way I can have enough information to know what the right thing is to do. But I did it once before and it turned out all right. Maybe it'll work out again, and if not, I guess I'll learn something and I'll figure it out.
Past performance does not guarantee future success.
Yeah.
Warning on the human body.
So I think still even taking this job after the military, this wasn't, I don't know, the safest job, or it wasn't the it has some unique challenges that I could have avoided in different situations. And
can you just talk about that? Like, so you tell me about, like, what was your job as a radiation oncologist in the Air Force compared to what your job is now? What are the things?
So the kind of the big thing is I did a lot of different things in the military. I treated all cancers in the military. I was program director. So getting back to your question that way, I segued on the residencies. It's a 5-year residency. And so it's 1 year as an internship and 4 years of oncology training, which is a lot of oncology training compared to what other fields. Medical oncology is 3 years, and surgical oncology is typically 1 or 2 years after a surgical residency. So I was a program director, so I was training residents at Walter Reed, and which was an enjoyable part of what I was doing, and taught me a lot of how do you become competent, and it's a lot of work. It's a lot of work in terms of understanding physics, understanding biology, and things that just take a lot of time to master so you can pass the test. How important they are, I'm not 100% sure, because I don't know how well I would do on the tests and my kind of last cohort of residents that I kind of take, a lot of ownership with they're waiting for the results of their oral boards, which is their last test that they have to take. And I wouldn't pass right now. But that's one part of it is learning the material that you need to learn. The other part is learning how to think. And I was a big thinker as part of my teaching, and I'm okay if someone didn't get what I thought was the right answer. And there's a lot of ways to get there as long as they were thinking through things and being smart and being able to learn and get better over time. And I would always, for the people that were struggling, I would draw a seesaw, and I would put solutions and problems. And I tell them your major job is to not create more problems. And so that was taught me a lot of how to think. Also, there's a lot of art. There's a lot of uncertainty that goes into kind of the practice of medicine, and being able to think your way through complex problems in a way to avoid big issues was kind of my way of teaching. Whether you got the right answer, I wouldn't necessarily say that this is right or wrong. I think there's some decisions that are better than others, or some that are dangerous and you shouldn't do. But there's a lot of ways to do things, and as long as you're safe, you think through things and you get better. That was kind of my approach to kind of creating a radiation oncologist, and it was an enjoyable component of what I did that I do miss. But it was time to move on. The military also, I had some lab research that I did. So I did some studies on mice and radio protection, and also was very involved with kind of the radiation nuclear response across the Department of Defense. That kind of got me understanding how big organizations think, and I was not surprised at all that we were very unprepared for the realities of a pandemic, because it wasn't something that leaders really wanted to think through. They want to have a plan, and the comment I would always get is, well, there's a plan for that. And my next one would be is, well, your plan's not going to work when chaos hits. But that wasn't what the objective was. The objective was to get a plan and move on to the next thing. So my military, I was able to think through complex problem solving and uncertainty, and have an opportunity to engage at high levels in terms of trying to get other people to acknowledge and understand how uncertainty and complexity match with the realities of being a human and developing plans and problems and solutions. But I never got any generals that were interested in me drawing my seesaw for them to explain. So my days in the military were somewhat numbered, because there was not room for Jeff Skinner in today's military.
Colonel Jeff Skinner.
Colonel Jeff Skinner, yeah. So I've got my trainees, and they hopefully have some of my inquisitiveness, and kind of they say I'm pretty particular, and so I think that's a special term of endearment is what I kind of got, but I guess I'll take it.
It's a carefully worded term.
Right.
Well, so I guess now you're in your current oncology practice, you're just treating patients. You don't have to, is that all you have to do now?
Yeah, that's all I have to do now.
And are you finding that because you have more time to do that and you're only focusing on prostate, that you're becoming, like, your knowledge base delving deeper is improving, or are you just able to treat a larger number of people and you already knew what you're doing?
Yeah, so I think treat a large number of patients. I mean, I'm bringing on something. I mean, so this is a plus and a minus to do less and to focus on one part. I'm trying to bring on some of the things that I think are important, that being able to focus on one thing can allow, focused decision making. Prostate cancer, it's an emotional decision, how to get better at helping people make those decisions, personalizing care based on new technologies that are just complex and hard to sort out. And how do you sequence that in and explain that to patients? And just trying to refine something that you do to make it better. So those are things that I'm doing. It's been harder to pull this off, than some of the parts I thought would be easy are hard. Some of the parts that I thought would be hard or easy. And so is my life simpler? Perhaps. Is it easier? Probably not. And the question comes in is, at what point is good enough good enough? Is always kind of a question that I wonder. And for me, I think the hard part is, part of my technique with the patients is, that they trust me, that they think I'm a straight shooter, that they think I'm smart enough to think through these things, and that if I'm if they want someone who's going to solve more problems than they may create, I might be your guy. But I've got to be able to pull that off. And my standards are what they are, and to kind of figure out whether you're meeting them or not. That's probably a challenge a lot of people have, of how good is how good. And I think it was my first year of medical school. And again, if I would have known what medical school would have been, I probably wouldn't have done that either. So I don't know what I would have done.
If you had all the information, you'd just stay. You'd been a surfer.
I would have stayed at home. I would have stayed at home, been a fisherman. I don't know, but someone had asked the question, like in the first year of it's just an anatomy instructor. I mean, not we just didn't have access to none of us really knew anything. And one of the questions was how much do we need to know? And the instructor was a British, kind of classic British anatomist, and he said, well, how much would you want your doctor to know? And so I'm like, well, I want my doctor to know everything.
Right.
And so I don't believe that now, but I'd say that's still a big struggle to have the no limitations. And I think that's a problem with the physician culture in general, and why there is, I think, a lot of physician dissatisfaction is, things are very complicated. I talked about the EMR. I could go into the billing. Like, I don't understand these things. I understand that they're not straightforward. They're causing problems, and you got to pay 5 people to figure out how to fix this, but they're not really communicating with me, and is the problem getting better? I don't know. But at the same time, do I know enough? Things are changing. Drugs are coming out. The statistics are extremely challenging to figure out, is this helpful or not? Medication's $50,000 and gives you 2 months survival. Is that worth it? Is it not worth it? There's just a lot to sort out. I don't think it makes people happier, especially if you're humble and you kind of understand this uncertainty, and end up with your own problems where you kind of want your doctor to know everything, but it's not possible.
Right. So it's complicated for you. It's, I'm sure, complicated and scary for a person that is just facing a cancer diagnosis. I have a relative who just recently got a prostate cancer diagnosis and has some testing coming up. When you're in that first situation, how should a person approach it? They're not guaranteed to get Jeff Skinner. They may or may not have. How do they even know where they should go, or how to do research? It seems like a complicated world to figure that out.
Well, I would say in some ways you got to get a little lucky. I think the first thing is understanding is whether this truly is an existential threat to your life. You've got to have some way to tier and understand the fear component. And so if this is an existential threat to your life and it's something rare and complex, you're going to need something different than just, the average person. It may be someone different than the Jeff Skinners that are out there. But a lot of cancer, while it ultimately could be an existential threat, it's not overly complicated. There's science, there's art that can vary that science, but if you get the 80% solution from someone who's trying to solve more problems than they create, that you're probably going to do as well as you would everywhere else. So I think that's the first part. You got to understand what you're up against, and the more your back's against the wall, that it's complicated. There's differences, there's challenges that are unique to you. I think those are the ones where going to big places or getting academic referrals are kind of mandatory, at least second opinions. So you got to know what that is, how you get to that point is someone's got to have some competence to tell you whether this is a big deal or not a big deal, and you may not be the best person to figure that out because you're fearful and it's such a big deal you can't really process it through. So I think that's the most important thing. You got to tier this in terms of what DEFCON level you need to be at, and that's your starting point. And then you got to build a relationship with someone, and hopefully you're decent at figuring out whether this person can accomplish what you need to accomplish. I guess if you're in a smaller place, you have less options. It's a little bit more challenging. But I can say from my parents and kind of being involved with some of their care, there's doctors that I like to deal with. There's doctors that I don't like to deal with. There's recommendations that I think are good. There's recommendations that I don't think, are good, and they can be hard to sort out. And whether that matters or whether it doesn't matter, it's a challenge. And the system matters.
Right. I remember that with Matthew's father going through treatment. Both of his sons are ER doctors. And so they have opinions, but the physician they are not their parents' physician. When you see conflict with someone that that's a friend, and they might not be taking the course that you would advise, do you interject, or do you trust the medical people that are their official physicians?
Well, I have a lot of equipoise with different things. I mean, in equipoise meaning, and there's multiple ways to get to.
I've never heard that word.
Yeah, so it's very important for cancer doctors, and someone who doesn't have equipoise may recommend a treatment or say this other treatment's not good, and that could or could not be true, based upon what data, what they're. So, but if I have equipoise, meaning I don't think there's a tremendous amount of difference, which for a lot of cancers, there is equipoise. I mean, you can try a new medicine that may have less side effects, but it may not be good as another medicine that has more side effects. It's very, very complicated, and some of them do very little. And you can really get wrapped up, with this kind of taking over your life and becoming the most, something that is you kind of lose sight of where you're trying to go, that can be hard. And kind of getting back to how I want to be with my patients, I think all of that is worthwhile to sort out, and to engage in, and to get advocacy, and to get second opinions, and to look for new medications. But you've also got to be very clear about what the purpose of all of this is. And again, one of the things that when I see my patients in follow-up, or when I see them, before they leave, I say, "What are you going to do fun this weekend?" After I ask them, for their job, I'll say, "Well, what do you do for fun?" What's fun for you?
Mm-hmm.
And the whole purpose of life is to have fun. And no one's getting out of here alive. And I think that I'm all for, advancing, getting second opinions, doing the best you can. If you want to think about cancer as a war, that's fine. I don't really like that terminology, but you've got to, in the end, understand the reason you're doing this is to have fun, to enjoy your life, to build something that's important for you. And that's the main part of this whole deal. And I see just that gets kind of confused. And I get confused with it, but that's, I think this is an opportunity and something I try to do different than maybe other people. I'd rather you live 2 years awesome than 5 years miserable, going from one treatment to the other. And that's not everyone's cup of tea, but that's how I try to look at things, and what I would want for, for myself. And if it's right for the patient, that I certainly want to give them, permission, to have an awesome life, and to not, to be freed by the fact that a cancer diagnosis finally lets me realize I'm not going to last forever. And maybe I should do what I want to do and not be held back by all the things that I can say or why I shouldn't try this.
Mm-hmm. Do you think in the private sector, I've heard, people say, well, physicians are owning their own radiology practices, and it's kind of one of these situations where they're a hammer and every patient's a nail. Do you think there are incentives that are maybe misaligned that cause physicians that are not you to recommend treatment just because, like, that's what we do, that's how we make money, and I always recommend this sort of treatment? Or am I oversimplifying it? And most physicians are really trying to say, hey, don't do this. You have, or look at this as one of 5 options.
Well, so I don't know, that's somewhat of a tricky thing, and I may go to the favorite thing of any physician when things don't go out. You just blame the patient for what they do. So I'll go there. That's another physician thing to do. I'll go through with patients that are 72 years old. I'll go through their cancer, and we've got special genomic tests, and I'll tell them that there's a 98% chance that this cancer is not going to take your life in 10 years. So 2% chance that it could have an adverse impact on you. You're 240 pounds. You're a diabetic. You have coronary artery disease. You have atrial fibrillation, and you're on an anticoagulant. You haven't changed your diet at all. You don't exercise at all. And it's just hard for me to believe that you're gonna live 10 years. This cancer is not the worst thing that's going on. That if you really wanted to change, you have got to cut out sugar. You've got to cut out alcohol. You've got to change that insulin resistance, and you've got to do it with the fervor of activity you've never done before. But you could do it. Or we could treat this prostate cancer, and you probably wouldn't have to worry about it. They take this 2% A down to 1%. And what do you think they like to choose?
They're scared of the cancer.
They're scared of the cancer.
Because of the word.
Because of the word, because the other thing is that's something that's out of their control. Me eating sugar, desserts are good, I'm going to do it. And so they're not going to do that. They're not going to change that. And I can treat them. And again, I try to be very careful to not cause problems because I know that this is a very, very small problem. But if I could, potentially funnel that funds into, to some way to motivate them to change their life, it'd be much more valuable. But you can't do that. I mean, that's, for whatever reason, and we're not blaming people. So we're trying to change things around the house. And, my wife last night said, well, maybe tonight should be a cheat night for desserts. And so it was, and it was tasty, and but sugar should be treated as a as a recreational drug, but we don't.
Right. I love cheat nights.
Yeah. So when a cheat night becomes a cheat week, that's when you know you're in trouble. And so, and again, you got to make your decision on what's important or not. But so I think there is that level of but I don't think that isn't our big problem. And so, as much as you want to say the system is set up, until there is really a change in how individuals interact with how they take care of themselves, and we're not equal. I mean, we're not equal. Some of us have bad genes. Some of us are more predisposed to having higher insulin levels. And if you eat the wrong stuff and you don't try harder than the next person, you're not going to do as well. And we're not equal. And so that's a much harder, much more difficult component to be done, but that's something that I'm going to start doing in my practice. And we'll see where it goes. But diet, exercise, looking at insulin levels, looking at these things that I think make a much bigger difference. I'll go for it, and we'll see where that's done. I've never kind of incorporated that into my practice, and I guess that's again one of the advantages of being able to focus on kind of one thing allows me to do.
You sort of alluded to this earlier. It's difficult when a person's facing a problem themselves. How much are you able to engage with a person's family or somebody else that might be a little more objective than the person that's in the fire? And do you find that to be pretty important in a person sort of navigating choppy waters of a medical diagnosis that's pretty scary?
No, I think first off, having a second pair of ears is kind of critical. I'm still amazed at how much people, they retain so little of what I say. And again, probably some of this is they're making decisions based upon what they feel and trust in an emotional decision. This kind of gets back to, again, like, well, how do you know you have the right doctor? How do you feel? What's your intuitive nature for that? But having a second set of ears is really important. And then having them be objective to some degree. It does happen where you have the second set of ears is the sky is falling, and then the patient is having to support the second person because they're falling apart. Oh, you're gonna you're gonna die and it's gonna be horrible. And then I gotta say, well, look, no one's going anywhere anytime soon. That's another one of my sayings, and it works most of the time, although sometimes people like, well, what does that mean? And they kind of get a little aggressive with me, and I got to back talk my way out of that. But ultimately, that and part of this whole question is cancer is getting old. I mean, is it a tragedy, or is it a normal part of life? And what's the definition of a tragedy? I tend to, with my approach and my demeanor, at least with my patients, I'm relatively stoic. I certainly have empathy, but at the same time, they have to figure out how to sort out what life is to them, and be comfortable with that. And it's harder if you're 56-year-olds, different than a 30-year-old. My kind of toughest patients were, at least for me emotionally, were gynecological cancers, cervical cancer patients and young mothers. Was really, it was extremely motivating for me. Built some of the most special relationships with them. But when things went bad, it's bad. And the lost quality of life and future does feel like a tragedy. there's some point where that, for me, that kind of equation shifts, and whether that's fair or not, I don't know. Maybe when I'm 72, we'll see. I'm sure something will befall me at some point, because no one gets out unscarred. But at some point it shifts, and I think that there's more lessons that can be gleaned and things. You can have them when you're younger, but I think it is, anytime a young person loses the opportunity to have a chance to reach their full potential, and they're very special people, and they leave people behind. I do think that is a tragedy of a different sort. But that's kind of my personal opinion.
Your work is meaningful, I'm sure. I can tell by the way you care about your patients, and sometimes there are bad outcomes. Do the difficult experiences of your profession weigh you down, or motivate you for the successful ones?
I think motivate. I think every physician who has to deal with this, has a case that kind of, test them. And mine came early in my career. It was a cervical cancer, patient that I ended up doing a lot of things that ended up not being helpful to her, and ultimately failed and controlling her disease, and she died a very painful, miserable death. And she was very thankful for what I did, and I remember finally telling her, when there was nothing else we could do, that I was sorry. I didn't do what I wanted to do. I didn't cure you. And she said that, that's all right. And that being able to have that time with her, and maybe she came along. I mean, I don't know how these things work. But I learned a lot from her, and she kind of gave me, I guess, permission to just do the best I can and be who I was. And I think everyone has to kind of go through that challenge and figure out where they lie on that. But certainly helpful for an oncologist that can have some type of peace with that, because if you took home everything, that would not be good.
Right. When you were weighing the decision for pilot training, medical school, I remember the debates. If I remember correctly, like the influence of your parents, your grandparents was important. And I was thinking about it on Memorial Day. I've got a picture of my granddad back here. I've never met him, but he's a World War II instructor pilot. And the influence of our families is important in the sort of early decisions when we don't have information. I'm curious if you can talk about the history in the Skinner family that may have influenced you to choose medicine.
Yeah, so I had a grandmother who had autoimmune. She had been a nurse, and she had autoimmune disease, and would have I don't know what they call fits of times where she was just bedbound, and then she would have times where she was in remission. She would do a lot of things, and this was back in the old days when you didn't have a lot of other things to do as a kid, so you just kind of were at the hip of your grandparents while your parents did other things. And so that was kind of my first kind of entry into, illness, and how illness was not good. It was not fun. I was, very young, at that time. And then when I was in fifth grade, my grandmother was diagnosed with small cell lung cancer. And I remember she was a big smoker, as many women were, back that this was, and I never liked that she smoked, but everyone smoked back then.
With sugar.
So she got small cell lung cancer, and my dad, his mom was very young. I think he was in his 30s, and so it's hard to think back to your parents and how, how well they did when they didn't know what was going on either with a lot of things. You think they knew, you think they knew things, and then when you get older, you realize they're winging it too. So anyways, I researched, as a fifth grader, I kind of researched what small, and so I knew she wasn't going to live. I knew this was, it had spread, this was a fatal disease, and no one else in my family seemed to understand that. And there was a time before she went in the hospital where she ultimately died from liver disease. It spread to her liver and to her brain. And she was so scared that she was going to die, because she knew she was going to die, but no one was able to have those conversations with her. And so that was really I remembered, I want to be someone that doesn't let this happen, because to me, she was so alone. And, I'm sure she wasn't, and again, how does life work out? But I'm not sure a 10-year-old boy was the right one to express that to, but there was no one else to express that to. And so, so she planted this kind of, component, to me. So that's one thing that I don't want people, fear is a big part of life, and we're never going to, if we didn't have that, it's just, you're never going to get rid of that. But being able to, to share that and kind of, I don't know, just be okay with that. And I see a lot of life, we're not as okay with that when it comes to, this process of life. And I think we would be better off if we were more, accepting of what's going to happen to all of us. We'd be better people. And so that was a big part of me. My grandfather then had leukemia. And so a lot of these experiences, were just kind of these intangible ones that were set into my heart and my psyche. It's just a part of who I am, makes me very comfortable in dealing with this. Coupled with the fact that it ended up I was a pretty good pilot, and I really enjoyed it. And it was, it was the most kind of freeing that it can be. I can still think back to, to doing barrel rolls at Pikes Peak and my first solo and just the way my mind was and just the flow that I was in. And I was really worried if I didn't go to that I would miss out on all of these experiences that were were that's why people love flying. There's just something amazing about it. And truth is I have, and I've traded off a lot of, uncertainty and anxiety and dealing with these other issues that, that at least I would have put off for a little point in time if I would have flown. But again, you can't go back to that. And I will say now, I still feel like I'm in the beginning of, a career and sculpting a life, that if I was a pilot, I don't know, I would be, I don't think I'd want to be an airline pilot. And so,
Right.
yeah, so ultimately, I think I quickly determined that the lifespan of a pilot is pretty short. That being, a young, experiencing those feelings has a lifespan, and can't do everything.
It's kind of like professional athletes.
Yeah.
Your first 10 years are awesome.
Yeah.
So you became a flight doc, right? Early
I did.
in your career. So you got to do some flying. For people like, all right, there's the Air Force Academy graduated on Wednesday. They've already made their decision. So maybe for the guys next year, like any, I don't know, advice for people that are maybe just entering, they're starting their medical training. How do you make the most of your educational experience and prepare yourself for what you've done, a marathon of learning and treating patients when you're at the start of your career?
Well, I think that the best way for anyone to do it now is just not to necessarily be set on a final objective that you want to get to. Now, I say that in that, for me, I always wanted to be oncologist, but it did make it a lot more rougher for me to do this path. So I suppose if you think you're something that you're destined to be, that maybe you should do it. But if you can avoid that, or you're not doing it because there's just some life experience that is set there, just be as curious as you can be. There's so many opportunities that are available. And in the military, I took advantage of a lot of them, but always trying to get to a destination kind of ruins a bit of the journey. And it's I don't know. Everyone has a friend that kind of just makes things, they don't seem to worry about too much. They go from one thing to another, and they kind of do real well, or if they're not doing well, they switch to something else. And I don't know if that's a skill you could develop early on. That I would say that's kind of a worthwhile skill to do.
Right. Well, you may be observing, my last podcast guest talked about the myth of the effortless achiever. And I think sometimes when you look at other people with flawless careers, we think they just had the destination there all the time, but they might have met a mix of luck and really hard work constantly.
Yeah.
Well, from a storied career in, the military and now the private sector, any experiences for you that stand out? A story that something that you like to tell about, like kind of how cool it is to be you.
Well,
or something you've learned.
Yeah. So I mean, there's I don't know. There's certainly a lot of things that I've learned, and I maybe just to tell two quick stories. One humorous, one not. I'll start with the humorous one first. It is so spring break for senior year, that we came up, so I was a big Ernest Hemingway fan, Jimmy Buffett fan, Key West fan. So came up with this idea to fly to Miami and take a sailboat to Key West. And so this was going to be a mix of Miami Vice, Blackbeard the pirate, Jimmy Buffett, Jacques Cousteau. We're going to get, diving equipment. And, so we set off, there was, 5 of us set off to do this. Now, quickly in today's world, it would take a 20-second, because I did it, a 20-second Google search to see how long does it take to sail from Miami to Key West, and you would have aborted the entire operation. It's like 4.5 days, depending on how, so it's like a 7-day trip. Like that doesn't, we're going to sail there, we're going to party in Miami, we're going to sail there, we're going to get there, we're going to party. Then so anyway, we like, I think day 2, we ran out of, Big Daddy's rum, and then, ran out of food on day 3, and, limped into Key West, early day 4, just a defeated, group of, not good pirates, so the pillaging was one night, and then we had to limp back, there. So good ideas sometimes, don't always work out. But again, like, man, those experiences in this story are, probably well worth it. And there's a lot more stories that are in it. And then
you would say you're kind of glad in retrospect you weren't able to Google it.
Yeah. So again, I think this idea now of just of too much information and too much thinking, and not enough just doing the experience. Everything is figure out what campsite should I go, how it can, and then you get irritated when things don't work out. I should have thought about that. I should have researched this, and so I think one of the things for me is to at some point go back to old school, and just whatever happens, and don't blame yourself, because the information's there. But I don't know, it's hard now,
right.
and now doing home renovations and YouTube and things, it's just getting worse and worse.
Yeah, you try to find out everything before you do anything, so there's no mistakes.
Right. Before you
and
just do it, you're like, oh, it's screwed up.
Now you research for 10 hours and it's still 2 times over budget and a month late.
Right. You still screw up. Now you just feel worse. So that one, and then I think just one to kind of end off for this Memorial Day and is so I was was in Iraq as a flight surgeon, and was right by the clinic when in September. I'd just been there for I don't know, probably a week, and helicopters landed. 3 helicopters landed full of some soldiers that were at Abu Ghraib had been mortared. And so I just was there, and so I was the first one to the flight line and started triaging them. And there was 6 that came in and called people in, and 5 of them were okay. They were talking and had shrapnel. There was 1 that wasn't, and so ended up by the triage, those ones got in first, and I ended up with the one that he was dead on arrival. But I'd done some month of trauma training. I wasn't a surgeon. I wasn't an ER doctor at that point, but knew how to put chest tubes in and kind of the protocol at shock trauma was everyone got 2 chest tubes and a needle in the heart before you would pronounce them. You just and you do it very rapidly. And so with the resources, it was just me and like 2 techs, and it was a big soldier, wearing, Army PT gear that they had worn. And, it just became evident to me that, despite my, I wanted to do these things, I wasn't going to get them done. And this guy was dead. And so eventually I stopped. And, and I just, thought, this American soldier, was killed, and just how easy it was for that to happen. And the rest of them did well. And what I think ultimately happened is he took all the shrapnel. He was closest to it. And so he took the shrapnel, and the other ones, didn't get it. But, and then for the rest of the time, just how easy, how quickly soldiers from both sides, but especially seeing an American soldier dead, and how easy it was for it to happen.
Yeah. Well, for Memorial Day, we do want to honor our classmates that are still with us. I guess all veterans that are still with us, and those that have gone on to the wild blue yonder. One of the cool things, Jeff, that I think you and I both remember is that the Air Force Academy football games, I think maybe all sporting events, at the end of it, the band will play the Air Force song. They'll play the 3rd verse. And for those that don't know this, it's kind of a meaningful little interlude in the middle of a festivity where we pause, everybody stands and stops and sings, and song starts out, here's a toast to the host of those who love the vastness of the sky. And it's cool to pause and remember and be thankful that we're still here to celebrate them. So
and the sacrifice that they all made.
Agreed. It's great to see you, Jeff.
All right. Thanks.
Happy Memorial Day to you and Brenda and all of the Skinners. And look forward to seeing you when I can be out on the East Coast.
Sounds good. Thanks.
All right. Take care.